You went to your last appointment feeling completely fine. No pain, no symptoms, nothing wrong. Just a routine visit, the kind you've been going to for years without thinking twice. And your doctor looked at your chart and said something like, "You're due for a few tests, standard stuff at your age. We'll go ahead and schedule those." You nodded. You probably didn't ask why, most people don't, but here is what nobody told you before you walked out of that office. Some of those tests, the ones being called routine, being called mandatory, being called just what we do at your age, have had their own guidelines quietly updated by the very medical organisations that created them. Updated to say that for healthy adults over 60 with no symptoms, these tests may be doing more harm than good. Not in rare cases, not in theory, in real people, with real consequences. People who walked into a clinic feeling exactly the way you feel right now. My name is Dr. Joseph Collins. I'm a medical health educator, and for the past 2 decades, my work has focused on one specific problem: the gap between what current medical research actually says and what gets communicated to patients in a 15-minute appointment. That gap is where people get hurt, not because their doctors are bad people. Most physicians are working hard inside a system that moves fast, bills by volume, and was not designed to sit down and walk you through the nuanced risk-benefit calculation for every test it recommends. That conversation takes time the system doesn't budget for. So you don't get it, and you leave not knowing what you weren't told. Today I'm going to close that gap, specifically for 3 checkups that are routinely presented as mandatory for adults over 60, but that the evidence increasingly questions for healthy, asymptomatic patients. Before I name them, I need you to understand one concept, because without it, nothing I'm about to share will land the way it should. It's called the cascade. Here is how the cascade works. You go in for a routine test. The test finds something. It might be small. It might have been sitting quietly in your body for years without causing a single problem. But the moment it shows up on a report, the clinical system does what it was built to do. It responds. A finding leads to a follow-up scan. The follow-up scan leads to a specialist referral. The specialist recommends a procedure. Just to be certain, the procedure carries risks. One of those risks becomes a complication. The complication requires treatment. And 6 months later, a person who walked into a clinic feeling completely well is managing 2 new diagnoses, 3 new medications, and a daily life that looks nothing like the one they had before. The original finding? Sometimes it turns out it was never going to cause harm at all. I've watched this sequence unfold in patients I genuinely cared about. And the hardest part is that it rarely starts with a mistake. It starts with a routine test. It starts with good intentions. And it ends somewhere nobody planned. I want to tell you about a woman I'll call Carol. Carol was 71 years old, retired, sharp as ever. She gardened 3 days a week, walked every morning, cooked her own meals. She had no chest pain, no unusual fatigue, no symptoms of any kind. She went to her annual checkup in good health and left with 3 tests scheduled. Tests her doctor called standard preventive care for her age. What happened over the following 8 months is something Carol has described to me as the period she lost herself. Not to illness, to investigation. We'll come back to Carol, because the question she asked me when it was finally over is the same question I want every person watching this to carry into their next doctor's appointment. But first, I need to give you something that will change how you hear everything I'm about to say. Here is what the research has established, and what rarely gets said plainly in a clinical setting. After 60, the calculation that makes a screening test sensible changes in 3 specific ways. First, many conditions detected through routine screening in older adults grow so slowly that they will never cause symptoms or shorten your life. You would live alongside them and never know they were there, if no one went looking. Second, your body's tolerance for the procedures that follow a finding is different at 68 than it was at 45. What is a manageable complication for a younger patient can mean weeks in recovery, a loss of independence, or a permanent change in quality of life for an older one. Third, and this is the part that genuinely surprises people, the research on some of the most common screening procedures shows that finding and treating certain conditions in healthy, symptom-free older adults does not actually improve how long or how well those people live. The outcomes are the same. But the risk of the procedure is real. That is not a fringe position. That is the conclusion of some of the most respected clinical bodies in medicine. 3 checkups. 3 conversations your doctor may never have started with you. I'll take you through each one. What it is, what the evidence actually shows, and what to say before you ever agree to schedule it again. Let's start with the first one. Checkup number 1. Routine colonoscopy. After 75, let me tell you what happened to Carol's neighbour, a woman named Grace. Grace was 77 years old, healthy, independent, still driving herself everywhere. She had 2 colonoscopies in her past. One at 58, one at 67. Both are completely clean. No polyps, no family history of colon cancer, no symptoms of any kind. Her new doctor looked at her chart and said she was overdue for another one. Grace didn't feel overdue, but she didn't feel like she could say that. So she prepared for the procedure. The liquid prep you drink the night before to clear your bowels. And by early the next morning, her daughter found her sitting on the bathroom floor, confused and barely able to stand. She was severely dehydrated. Her electrolytes had dropped to a level that was putting real strain on her heart. Grace spent 4 days in a hospital, recovering from a preparation for a procedure she never ended up having. Here is what Grace was never told before she agreed. The United States Preventive Services Task Force, the independent body that sets the national standard for screening guidelines in this country, formally recommends against routine colonoscopy screening for average-risk adults over the age of 75. The evidence behind that recommendation is specific. After 75, for a patient with no symptoms, no family history, and previously clean results, the risks of the procedure begin to outweigh what it can realistically offer, and those risks are not small. Bowel perforation, a tear in the colon wall, occurs in approximately 1 in every 500 colonoscopies. In a younger patient, that is a serious but manageable surgical complication. In a woman in her late 70s, it can mean emergency surgery, extended hospitalization, and a recovery that permanently changes her daily independence. The other side of the equation is equally important. Colon cancer is slow-moving. If a polyp began developing in Grace's colon the day after her clean scope at 67, the research tells us it would take roughly 10 to 15 years to become a genuine threat. Statistically, Grace was far more likely to reach the end of her natural life before that polyp ever became dangerous, while facing very real and immediate procedural risk in the meantime. If you are over 75, have had previously normal results, and have no symptoms, no blood in the stool, no unexplained changes in bowel habits, no significant weight loss, the question worth asking your doctor is this: given my age and my previous results, what does the current guidance actually recommend for someone like me? The answer may surprise you. Checkup number 2. Routine. PSA testing after 70. This one requires care because the conversation around prostate cancer screening is emotional. And it should be. Cancer is not a word anyone hears without weight. But here is something that most patients are never told before they agree to a PSA test after 70. Autopsy studies, research conducted on men who died of entirely unrelated causes, have found that between 60 and 70% of them had prostate cancer cells present in their bodies that they never knew about, never caused pain, never caused symptoms, never threatened their lives in any way. These were men who died with prostate cancer, not from it. The distinction matters enormously because the moment a PSA test returns an elevated result, the clinical system responds. A biopsy is recommended. The biopsy carries its own risks, including a 2 to 3% chance of serious infection, which is higher in older patients. If the biopsy finds cancer, and in men over 70, it often will, precisely because slow-growing prostate cancer is so common, the pressure toward treatment begins. Radiation, surgery, both with significant lasting side effects. The European randomized study of screening for prostate cancer followed over 160,000 men across more than a decade. For men over 70, PSA screening did not reduce deaths from prostate cancer. What it did produce was a substantial increase in biopsies, surgeries, and radiation treatments. All for cancers that, in the majority of those older men, would never have caused harm. The American Cancer Society, the American Urological Association, and the US Preventive Services Task Force all now advise against routine PSA screening after 70, unless a man has a strong family history or specific symptoms that warrant investigation. This is not a controversial position anymore. It is the medical consensus. What makes it complicated is that nobody explains it in the room. The test is fast, it costs almost nothing, it gets ordered automatically, and once the number comes back elevated, the conversation about whether to investigate becomes much harder to have calmly. The time to have it is before the test and not after. If you are a man over 70 with no symptoms and no strong family history, the question worth asking is, if this test comes back elevated, what realistically happens next? And given my age, is that a path that is likely to help me? That single question, asked before the blood is drawn, changes everything that follows. A word before the third checkup. I told you we would come back to Carol. Carol's 8 months of investigation, the follow-up scans, the specialist appointments, the procedure and the complication that followed, were all set in motion by the third checkup I'm about to describe. It is the one that surprises people most, because it sounds on the surface like the most responsible thing a doctor could possibly suggest. Stay with me. The third one is next, and it is the one I want you to understand most completely before your next appointment. Checkup number 3, routine cardiac stress testing without symptoms. Carol's doctor called it a precaution. She was 71, her doctor explained, and it was simply good medicine to make sure her heart was doing well, even though she had no chest pain, no shortness of breath during her morning walks, no dizziness, no palpitations. Nothing. Just to be safe were the exact words used. Carol got on the treadmill. The test came back with an abnormal reading. What followed was not a conversation, it was a referral. Then a cardiac catheterization, a procedure where a thin tube is guided through an artery in your wrist or groin directly into the blood vessels of your heart, while dye is injected to image them. The catheterization found a partial blockage, 40%. Her cardiologist said they should place a stent, a small mesh device opened inside the artery to keep it from narrowing further. Carol asked if she had a choice. She was told it was the safer option. She had the stent placed. Within weeks she was on blood thinners, medication she would need to take for the rest of her life to prevent clotting around the device. Those blood thinners came with their own risks. A minor fall 3 months later, the kind she would have walked away from before, sent her to the emergency room with internal bleeding. Here is what Carol was never told before any of this began. 2 landmark clinical trials, the Courage trial and the Ischemia trial, both published in the New England Journal of Medicine, followed thousands of patients with stable coronary artery disease and no significant cardiac symptoms. Their conclusion was direct. In patients like Carol, no chest pain, no shortness of breath, no functional limitations. Aggressive intervention through catheterization and stenting did not reduce heart attacks. It did not extend life. It delivered no better outcomes than careful medication management and lifestyle support alone. The stent carried all the procedural risk. The medication would have achieved the same result with none of it. But the cascade had already started. And once a catheterization finds a blockage, the momentum toward intervention is extremely difficult to stop, even when stopping might be the medically superior choice. There is something else worth understanding about cardiac stress tests specifically. In older adults, and particularly in women, the false positive rate for cardiac stress testing can reach 40% or higher. That means nearly half of all abnormal stress test results in this population are flagging a problem that does not actually exist. But medicine cannot simply look at an abnormal result and do nothing. So the catheterization gets scheduled. The cascade begins, not because anything was wrong, but because a test said something that turned out not to be true. Carol asked me, during a conversation after her recovery was finally complete, the same question I've been asked by patient after patient who found themselves in a similar position. She said, "Dr. Collins, if I had known to ask one question before I agreed to that first stress test, just one, what should it have been?" I told her the answer is always the same question, and it applies to every screening, every test, every procedure that gets presented to you, as routine or mandatory, or just what we do at your age. The question is this: if this test finds something, what will we do about it? And is that something that is genuinely worth doing for someone my age, in my current health? That question does something important. It forces the conversation about the cascade before the cascade starts. It moves the discussion from findings to outcomes. It puts you, your life, your daily function, your values, at the centre of the decision rather than the test result. Any physician who is practicing good medicine will welcome that question. They will slow down. They will think it through with you. And if they can give you a clear, honest answer, proceed with confidence. But if the answer is vague or rushed, or if the question itself seems to make them uncomfortable, that is important information too. What this is not. I want to be direct about something before we close. Nothing I've shared today is an argument against medicine, against doctors, against care. Preventive medicine has extended and improved millions of lives. Blood pressure management, diabetes monitoring, vision and hearing checks, annual medication reviews, vaccination. These are valuable, evidence-supported, and worth keeping. What I'm asking you to do is go to your next appointment as a participant, not a passenger. You have the right to understand what a test is looking for. You have the right to know what happens if something is found. You have the right to ask whether that finding would actually be treated, and whether that treatment would genuinely improve your life. Not just produce a finding on a report. Write Carol's question down if you need to. Put it in your phone. Bring it to every appointment from this point forward. If this test finds something, what will we do about it? And is that worth doing for someone my age? Ask it before the colonoscopy gets scheduled, before the PSA blood is drawn, before you step onto the treadmill. Because the most powerful moment in your healthcare is not the moment after a result comes back. It is the moment before you agree. A final word. The 3 checkups we covered today are not the only ones worth examining carefully after 60. They are simply the ones with the strongest evidence behind the conversation, and the ones most likely to appear on your next scheduling list without a single word of explanation. If this gave you something useful, share it with someone you love who is over 60 and has never once questioned a test their doctor scheduled. The most important thing you can do for their health today may simply be giving them one question to ask. I'm Dr. Joseph Collins. Take good care of yourselves. I'll see you in the next one.